Thank you for the opportunity to discuss the innovation on drug-resistant tuberculosis and management and implementation in the field. So in this talk, I'll give you an overview of the epidemiology of the drug-resistant tuberculosis, a review of the newer concepts in the treatment of active drug-resistant tuberculosis, and update on approaches and its implementation in the field. TB has received a lot of attention in the recent years, and recent in United Nations high-level meeting in September of 2018, there has been several General Assembly declaration and commitments, which includes a goal of ending the TB epidemic globally by 2030. In these declarations, the goal was to treat at least 40 million people with TB between 2018 to 2022, including 1.5 million people with multi-drug resistant TB. That also includes 115,000 children. And also increase the global investment in TB prevention and care to 13 billion per year by 2022, and also increase the global investment in TB research to 2 billion per year. There has been a large gap in global investment in TB research of 1.3 billion, which where it has to be cut by almost the entire amount by 2030. So as per the recent Global Tuberculosis Report of 2023, which has been outed by World Health Organization almost every year, has an NTB strategy for 2016 to 2035. It has three main indicators. The first one is the reduction in number of tuberculosis deaths compared with 2015. And the goal is to achieve at least 75% of reduction by 2025 and 95% reduction in 2035. Similarly, reduction in the TB incident rate to be reduced by 50% by 2025 and 90% in 2035, and also reduce the catastrophic costs due to tuberculosis by TB participants or patients as well as their households to be zero throughout. So where are we in 2022? The estimated TB incident rates were very, very high, and about 7.5 million newly diagnosed TB cases were notified in 2022. And as you can see, most of these cases are in sub-Saharan African region as well as in South and Southeast Asia region. Of the countries with very high TB burden, about 68% of global cases in 2022 were seen in 8 countries, and majority of these countries are in South and Southeast Asia, including India, Philippines, Bangladesh, Pakistan, China, and Indonesia, while Sub-Saharan Africa also has a large number of burden. Most of these are driven by their HIV epidemic. Having said that, global TB incidence has continued to decrease from 2010 to up till 2020. But because of the COVID-19 pandemic, now we see a slight increase in TB incidence cases, as shown here in the graph. Best estimate for 2022 is 10.6 million TB incidence, but it is up from 10.3 million in 2021 and 10 million in 2020. However, the cases of MDR or multi-drug resistant or rifampin resistant TB has been relatively stable between 2020 to 2022, although there has been reduction in MDR RR-TB cases since 2015 to up to 2020. The deaths caused by tuberculosis, again, there has been a net reduction of 19% between 2015 and 2022, but the goal for this period is almost 35%, and that is, this reduction is much lower than what has been expected, and In 2022, there was 1.3 million deaths occur, which is actually reduced from 2015 from 1.62 million. And majority of the deaths among all participants are still quite high at 1.13 million population, and the deaths, which is estimated by just HIV and AIDS, has been 0.63 million. Therefore, TB remains now the leading cause of all-cause mortality from infectious diseases after COVID-19, which is slightly higher than TB at 1.24 million people. There has been a great stride in number of people who are treated for multi-drug resistant or rifampin-resistant tuberculosis. As you can see, from 2010 until 2018, there has been a steady increase. But over the last 4 years, between 2018 to 2022, the number of cases got treated are 825,000 people with MDR and XDR, MDR and rifampin-resistant TB or XDR TB. The target for this period has been 1.5 million people, and so the target has been missed almost by 45%. So what are the traditional MDR TB treatment? We have known for a long time MDR TB treatment requires a long-term management with injectables as well as oral medications. Will have between 20 to 24 months of treatment, could have an intensive phase ranging anywhere between 4 to 6 months, and continuation phase for up to 18 months or so. And this has been around for a long time, and also sometimes optimally managed by optimized background regimens based on the availability of the drugs, as well as based on the patient's TB resistant patterns. And these kind of treatments have been having varied success, anywhere between 40% to 85%, based on where these patients are from and availability of the drug, as I mentioned. After a long phase of being on a very long treatment regimens, there has been several clinical trials which looked into whether treatments can be shortened or can be converted from injectables to an oral regimen, and so on and so forth. And here is one of those trials called STREAM-2 trials, which was a trial, open label, multi-center, randomized, non-inferiority trial, which randomized participants with rifampin-resistant TB, MDR TB, to either a control regimen, which consists of whatever is given in the settings, or oral regimen, which has all oral medications given for 40 weeks, or 6 months regimen of some of those medications as shown here, given for 8 weeks of intensive phase, followed by 4 months of continuation phase. So the results of this was encouraging, that the number of participants with favorable response were much higher with the oral regimen, as well as 6 months regimen, compared to that of the control regimen, which consists of injectables as well as oral medication for a longer duration, anywhere between 9 months to 18 to 24 months. So the difference in favorable response was much higher for 6 months regimen. Both of these regimens, oral regimen as well as 6 months regimen, contained bedaquiline as one of the drugs. So as you can see, there is a huge difference in favorable response with the 6 months regimen, as well as all oral regimens as well, which reached statistical significance. Since then, there has been a couple of trials which looked into bedaquiline, pretonamide, and linezolid combinations. This is one of the first publication which is a single arm trial or a study which looked into this regimen at the doses shown here: pretonamide 200 milligram, bedaquiline 200 milligram 3 times weekly after 2 weeks of loading dose, and linezolid 1200 milligram once a day, were given for participants with XDR TB or refractory or non-responsive MDR-TB. And these participants were followed for 6 months for post-treatment and follow for relapse-free cure for over 24 months, that is about 2 years. And the results, this study was also called NICS-TB, and the results showed that favorable response was seen among 90% of the population. And it is almost similar among XDR-TB participants at 89% and MDR-TB participants 35%. And the effectiveness was similar whether they had HIV or they did not have HIV, as you can see here. Following that study, the ZNIC study, which is a multi-center randomized partially blinded phase 3 trial, was conducted. And this study randomized participants to either BPaL with linezolid 1200 milligram once a day for 6 months, or BPaL with linezolid 1200 milligram once a day for 2 months, BPaL 600 milligram linezolid for 6 months, or linezolid once a day for 2 months. And the participants included individuals who are extensively or pre-extensively drug-resistant or treatment intolerant, non-responsive multi-drug resistant treatment. And they are evaluated for 6 months after the end of the treatment. And the primary endpoint was bacteriological failure, relapse, or clinical failure until 6 months after the end of treatment. The results of the ZNIC trials are shown here. As you can see on the left-hand side, the favorable response was seen in almost all of those arms, close to or above 85%. But the arms which had the most efficacious were the ones which had linezolid 1200 milligram once a day given for 6 months, and linezolid 600 milligram once a day for 6 months. And so this trial showed that even with the lower dose of linezolid, the 600 milligram has a comparative effectiveness as compared to 1200 milligram dose. As we know, linezolid has significant significant toxicity, including peripheral neuropathy as well as hematological toxicity. Therefore, lower doses are considered to be safer and preferred compared to 1200 milligram dose. This trial, which looked into all oral regimen for rifampin-resistant TB tuberculosis, called TB Practical trial, randomized participants to either BPaL regimen with moxifloxacin 300 milligram given, or BPaL regimen with clofazimine, BPaL regimen with BPaL regimen by itself, or WHO standard of care, which included injectables anywhere between 9 months to 24 months as per the local standard of care, and looked at the unfavorable treatment outcomes at 72 weeks post-randomization. As you can see over here, the unfavorable response kind of ranged between in the control arm up to almost 50%, but the BPaL regimen about 23%, BPaL M regimen only 11.3%, which is shown in this figure on the left-hand side, showing that risk difference for the culture conversion at 8 weeks, at 12 weeks, were similar between BPaL M regimen as well as SOC. However, risk difference at 72 weeks for the clinical outcomes, which is treatment failure, relapse, or death, are quite significant, minus 29.2% for BPaL M regimen. M stands for moxifloxacin. And this is also shown here in this figure that at 72 weeks post-randomization, BPaL M regimen only had 11.3% unfavorable outcome, and the risk difference was almost 37.2%. So this study, this trial, showed that 24 weeks all oral regimen containing a backbone of bedaquiline, pregabalin, and taper dose linezolid are safe and efficacious in treatment of rifampin-resistant tuberculosis. And there were about 153 people living with HIV as participants, and effectiveness was similar between them and HIV negative participants. There has been another comparison among XDR-TB participants as well as NICS-TB trial participants in South Africa, which showed that unfavorable outcomes were much higher at 35.3% among XDR-TB participants compared to NICS-TB participants, but still the outcome of favorable outcomes were seen among close to 65% of the XDR-TB participants compared to almost 90% of the NICS-TB participants, and therefore the treatment success rates are much higher with the BPaL regimen, even if the participant or patient has XDR-TB. So all of these trials resulted in a rapid communication in May of 2022 on the key changes to the treatment of drug-resistant tuberculosis, which was published by WHO, that stated that all patients with MDR or rifampin-resistant tuberculosis, including those with additional resistant fluoroquinolones, stand to benefit from the effective all-oral treatment regimens, either shorter or longer, implemented under the programmatic conditions. And they specifically recommended a 6-month of BPaL M regimen or BPaL regimen by itself, based on the susceptibility pattern for fluoroquinolones among these MDR or pre-XDR participants. So drug susceptibility to fluoroquinolones, however, was strongly encouraged because that would help determine which regimen to be given to these patients. There has been a systematic review and a meta-analysis, which was recently published, showed that bedaquiline, pretamine, and or linezolid containing regimens among RR-TB participants does have close to 6.5-fold higher treatment success rates compared to a standard of care regimen, which was standard at that local region at that time when these trials or studies were conducted. So where are we in terms of this implementation in the field? So the first question is, why implement a shorter regimen? So we know the science, which I already discussed about TB Practical, NICS-TB, and ZNICS trial. And what about the implementation processes in the field? So being a shorter course, it will be easier to complete from the standpoint of patients. They are all oral drugs, which is more attractive to the patients, and then potentially lower healthcare costs, lower logistic burden for the program, and distribution burdens are also lesser because it's only 6 months. And for the participant point of view as well, there's a lower indirect patient cost in terms of how many times they have to come for follow-up visits, so transport costs or loss of wages and so on and so forth. Again, lower cost to the program with the short course. So they have lesser human resources costs, lesser cost of maintenance of medications for a longer time. So we know that the cost of BPaL has reduced from what it has been before, and now it is about $720 USD per treatment cost, could be even reduced to $564, which is almost similar to what is the cost for a normal previously given traditional MDR-TB treatment cost, but it included injectables. In 2021, a BPaL regimen programmatic introduction guidance was published by Stop TB Partnership with TB Reach as well as TB HIV Investigative Network, which discussed the component of the BPaL regimen, bedaquiline, pretamine, and linezolid, and its experience being used for outside of MDR or drug-resistant TB. And the dosages which has been reviewed and approved as shown here. Again, we already mentioned about bedaquiline being a part of the BPaL regimen, can be given to participants at the time for 6 years or older who have at least 15 kgs of weight, and adults it can be given as a 400 milligram once a dose for 2 weeks and 200 milligram 3 times per week. Similarly, pretamimide is at the time recommended for pulmonary XDR or treatment intolerant or non-responsive MDR-TB, and we can be given for adults 200 milligram once a daily. Linezolid has been in use for the longest time for various gram-positive infections and pneumonia and so on. When the BPaL regimen originally was dosed at 1200 milligram, but now it's been reduced to even 600 milligram once a day for 6 months, and dosages can be managed for children as well, as we have a lot of experience with linezolid. And the drug-drug interaction has also been studied for bedaquiline, and there has been guidance for that as well for programmatic use. And the side effects of most of these drugs are known, including increased mortality with bedaquiline level and QTc prolongation. And in the case of pretamimide, hepatotoxicity, and linezolid, as we discussed earlier, peripheral neuropathy, anemia, and other issues. So what about the resistance, of baseline resistance for these BPaL group of regimens? And this paper discussed the baseline resistance for bedaquiline and pretamimide has been excessively low at 1 to 2%. In case of pretamimide, even lower at 0.7%. So it is very encouraging to see that baseline resistance at low. Therefore, it can be widely implemented, and cost effectiveness of bedaquiline, pretamimide, linezolid may come down significantly as the pretamimide, as being the newest medication in the group, their cost reduces significantly over time. As part of programmatic implementation via LIFT-TB, several countries have started implementation research in 2021, and these include many countries in South and Southeast Asia, Indonesia, Vietnam, Philippines, Myanmar, Kyrgyzstan, Uzbekistan, and Ukraine. And TB Reach commenced some of these programs in Ukraine and Tajikistan, and other donors in India and South Africa and other places have also commenced implementation research for the BPaL regimen, and several other countries are also in process of starting these implementation research. There has been some data available on safety and effectiveness of BPaL regimen as per the multi-country operational research cohort, which was presented in the Union meeting in 2023 in Paris. One of those abstracts, among many, were from KNCV network, where implementation occurred in Indonesia, Kyrgyzstan, Vietnam, Philippines, and Uzbekistan. About 319 MDR and RRTB treatment intolerant non-responsive fluoroquinolone resistance participants were enrolled, who had a median age of 40 years, and about 59% were males. And of the data available by the time the Union meeting happened, in 146 participants who completed treatment, over 95% had treatment success. That means that they had cured and treatment completed by the time this abstract was published. And the participants who had hepatotoxicity were rare. Only one participant had that. QT prolongation was also seen in a very small number of participants, as well as myelosuppression, neuropathy, were fairly common in anywhere between 25 to 30% of the participants, but they were all manageable and did not require treatment discontinuation as per the team who presented these data. Further, in the 2022 Union virtual meeting, there were several presentations on clinical experience with the clinical access program in South Africa, from Philippines, as well as from Ghana and Ecuador. All of them presented very encouraging results that the acceptance of these regimens were higher, completion of these regimens were higher, close to 80 to 90%, although number of participants at that time were much lower, in less than 100 or so. A recent publication in Clinical Infectious Diseases discussed the implementation of this BPaL regimen in the United States. where about 70 participants from US and other territories with a median age of 37 years. Majority of them who were non-US born were given BPaL regimen. Of the participants, 70 participants, about 68, almost 100%, completed the prescribed course of 26 weeks of BPaL. And the loss to follow rate was pretty low. In this case cohort, participants' linear doses were monitored and were tapered as required or replaced by the clinicians based on the clinical requirements. And this cohort shows that it can be easily implemented not only in resource poor countries, but also in resource-rich countries with very good success rate. What about the global adoption of the 6 months drug-resistant TB regimens? What are the projections on its uptake? This recent paper published by Stop TB Partnership Group showed that individual treatment regimens over the course of next 3 years, between 2023 and 2026, will decline rapidly, while longer all-oral regimens would also make, which has made a great stride in 2023, will also be reduced, while BPaL regimen and BPaL-M regimen uptake will significantly increase based on their assessment and surveys with multiple countries and multiple countries' programmatic stakeholders, and they propose that the positive change will occur between 2023 and 2026 by 12%, and over 500,000 potential patients will be on this BPaL or BPaL-M regimen over the next 3 years. There has been several papers looking into acceptability and feasibility and likability among the stakeholders who are implementing the novel regimen. And majority of these studies, including the one shown here, which was conducted in Indonesia, Kyrgyzstan, and Nigeria, show that acceptance rate would be very high by the stakeholders, although they do foresee some challenges, including the availability of medications and monitoring of treatment in terms of side effects and how to manage those side effects and so on. But overall, the notion from these program stakeholders have been that this is going to be highly effective and highly acceptable and feasible to be scaled in the programmatic settings. So where are we right now? There has never been a best time to do TB science, as there are over close to 40 newer medications which are in different phases of development. Some of them are being used in various upcoming trials, and there has been over 15 new TB vaccine pipelines, which are also can be used either as a pre-exposure or post-exposure, including treatment shortening trials or as an indication, including for drug-resistant TB. So this field is rapidly changing in terms of what would be the optimized treatment regimens as well as treatment duration for not only drug-resistant TB, but also drug-sensitive TB. And as I mentioned, the TB vaccines, there are diverse vaccines, which are either adjuvanted vaccines or viral vector vaccines or whole cell mycobacterial vaccines, as well as live vaccines. So in summary, TB continues to be a leading cause of morbidity and mortality. Drug-resistant TB incidence remains constant in the last 2 years. Mainly, this affects the sub-Saharan Africa and Asia regions. However, global treatment targets have been missed consistently over the last 7 years. And we now have a shorter course of drug-resistant TB, which is shown to be effective, acceptable, feasible to be implemented in various settings. And with that, I would like to acknowledge the team which works steadfastly in our setting in India, without which we cannot participate in any of the clinical trials which we are part of right now for tuberculosis, HIV, and antimicrobial resistance, and my colleagues who helped with some of these slide sets. Thank you very much.
Thank you very much, Vidya, for your excellent presentation.